Welcome everyone. Apologies for the slight delay. There was silence from both our ends. So many thanks for having me on today to talk about two subjects, aplastic anemia and paroxysmal nocturnal hemoglobinuria. And thank you for the AMDS International Foundation for giving this invite and asking me to talk on this topic, which is close to my heart. So my name is Dr. Kulasekararaj. I'm a consultant hematologist based at King's College Hospital in London. So what I thought I will go over in the talk was new developments in the field of aplastic anemia and PNH, and how do we incorporate these new developments into the existing algorithm, and what is also anticipated and what could be interesting in the next few years. I thought I'll give you a couple of updates on the relationship between COVID, aplastic anemia, and PNH, and also relation to vaccination. And lastly, I'll sum it up with an update on the global PNH registry. So some of the talks might be very fundamental, but I just want to take you through this so that everybody is on the same page. So what is aplastic anemia? So aplastic anemia is I would say it's a pure autoimmune disease. It's a disease where diagnosis of exclusion. So you have your normal bone marrow producing loads of stem cells, and stem cells producing these red cells, white cells, and platelets. You have an autoimmune attack or an attack on the bone marrow stem cells by abnormal immune system. This leads to empty bone marrow or marrow aplasia, which is where the name aplastic anemia comes. More appropriate and apt description would be that this is a bone marrow failure rather than just anemia, because these patients develop, unfortunately, anemia, low platelet count, and also low white cell count. So it's essentially a bone marrow which contracts and your stem cell pool is extremely low. One of the interesting things I thought, which I picked up from European Hematology Association presentation on the biology of the disease, was a large series where they looked at a novel autoantibody against a particular thing called cyclooxygenase 2, which is COX-2. People might remember historically there were drugs which were COX-2 inhibitors called celecoxib and melicoxib, and a number of drugs which were used as anti-inflammatory. So essentially, these group looked at this autoantibody against this COX-2, and they were able to detect this antibodies in a high proportion of patients with aplastic anemia, but not in other autoimmune diseases. So can this be a biomarker which can be used in a diagnosis of aplastic anemia? We all know that in patients who develop aplastic anemia, at whatever age it might be, we want to make sure that these patients have an underlying history, because we know that 80 to 90% of cases of aplastic anemia is what we call it as idiopathic or immune mediated, where we don't know the cause of this bone marrow failure or dysfunction. They could potentially have normal documented blood counts before the presentation with aplastic anemia. But we also need to be careful that in about 10 to 20% of patients, this aplastic anemia could be a marker of the underlying genetic defect which manifests a bone marrow failure. So we always look for other features which give us some subtle clues. Is this patient has got an immune-mediated or idiopathic aplastic anemia, or is there signs of genetic or inherited or constitutional bone marrow failure, i.e., there is a defective gene which leads to the bone marrow stem cells to go into lack of production and bone marrow failure. And I've sort of illustrated some of the things which we look for in patients to make sure that we are not missing any sinister and subtle clues in the history, personal, family, or other history, which will help us to come to a diagnosis of aplastic anemia. We all know that in the context of aplastic anemia, which is a bone marrow failure and an autoimmune disease, it can sit in together with patients who present as myelodysplastic syndrome, which we know is a malignant or a clonal disease. And we know that there are a group of patients who sit somewhere in the middle, presenting as hypoplastic myelodysplastic syndrome. And also to show in this cartoon that the genes which are associated with bone marrow failure, the genetic component of the bone marrow failure, is expanding and expanding as we learn more and more about the genetic causes of bone marrow failure. And there were quite a lot of data on GATA2 and DDX41 in EHA of 2021. And despite this, we also know that in about nearly third to half of the patients, we are not able to characterize why these patients have a so-called potential genetic cause for the bone marrow failure. Additionally, in King's and a number of other centers, we know whenever a patient presents with bone marrow failure, if there are subtle clues that there could be an inherited component, we look for a number of genes which are associated either with bone marrow failure, neutropenia, thrombocytopenia, or also Diamond-Blackfan anemia, which are other genetic causes of bone marrow failure. So whenever a patient presents with bone marrow failure pancytopenia, we always want to rule out that there is no constitutional bone marrow failure element, because that has got significant implications for treatment, prognosis, and also counseling. Additionally, this is a data which was published recently, which goes through these three things. If a patient presents with aplastic anemia, if they have a PNH clone, or this chromosomal abnormality by particular genetic screening, or this abnormality in the T cell gene rearrangement, if these three factors are ticked in, then they have a high specificity and a high positive predictive value that if someone presents with bone marrow failure, and if they have a PNH clone or a copy neutral loss of heterozygosity and 6p, then the PNH copy neutral loss of heterozygosity on 6p, this goes more in terms of an immune-mediated bone marrow failure. And this was elegantly shown by a number of studies as well. But one thing I'll always be concerned about is if a patient presents with pancytopenia, you need to make sure that they do not have hypoplastic myelodysplastic syndrome, because this is a disease which has got different implications, different connotations, both in management, prognosis as well. So we need to make sure as hematologists that this patient does not have any component of underlying myelodysplastic syndromes, and subtle clues needs to be picked up. So now we have diagnosed somebody with aplastic anemia, because as you all are aware, aplastic anemia is a diagnosis of exclusion. You do not look at a bone marrow and say somebody has got aplastic anemia. You look at the bone marrow and say they don't have this, they don't have other things, they don't have fibrosis, they don't have infiltrative conditions, they don't have leukemia, they don't have other odd features, and it's a diagnosis of exclusion. And that is why it's not uncommon for patients with aplastic anemia to have a couple of bone marrows before you arrive at a diagnosis. So what are the treatment options for aplastic anemia? And again, similar to the disease, there are only, technically in a broad brush, there are only two treatment options. Would these patients benefit from a transplantation, or would they benefit from immunosuppressive therapy? And this is the data many, many years comparing these two, and again showing that in a certain subgroup of patients, which we will come to next, those patients would benefit with an upfront transplantation if they have a sibling donor. But if they do not have a sibling donor, then they need to go in for ATG cyclosporin. But I'll come back to that in a minute. And there are a number of transplant regimens, conditioning regimens for transplantation, depending upon the country which the patient's in. In UK, we tend to use the fludarabine cyclophosphamide campeth-based regimen with GVHD prophylaxis being cyclosporin alone. Commonly used is an FC, fludarabine cyclophosphamide ATG regimen, but in younger people, the regimen used is hydrocyclophosphamide with ATG as well. So there are a number of regimens which have been used in different parts of the country with significantly improving success rates over the period of time. So how do you decide on what treatment this patient needs to get? And this is always based upon age of the patient. If they're less than 40, if they have a sibling donor, yes, go ahead to have a transplant with a sibling donor. If no, and provided you've ruled out that there is no constitutional bone marrow failure or inherited genetic bone marrow failure, because you would not want to use a sibling in that setting. So if they do not have a sibling donor and you rule out constitutional bone marrow failure, then they will go on to get HOS ATG and cyclosporin. If they're more than the age of 40, same treatment. But I know at least in US, Canada, and a few other countries, now 3-drug regimen is the standard of care for anybody who does not have a sibling donor, match sibling, and they're less than 40 or more than 40, irrespective of the sibling donor. Patients usually go on to get HOS ATG, cyclosporin, and L-Trombopac. I'm aware that this is not the same across multiple regions in the world, but at least in US and Canada and a few other countries, the triple drug regimen has become the standard of care. How did this become a standard of care? This is based upon a data 4 years back published in New England Journal of Medicine using 3 drugs in upfront treatment of patients with aplastic anemia. What did it show? It showed that patients on the triple drug regimen compared to ATG and cyclosporin had a different response rate at 3 months and different response rate at 6 months. And if you look at the cohort which received L-Trombopac immediately after the ATG or on day 1, along with it for 6 months, up to 92% response rate at 3 and 6 months, and a complete response rate of 40% at 3 months and 60% at 9 months. So, but still, these are things which we need to be careful about and monitor these things carefully, including monitoring for relapse, PNH clone, and also karyotypic abnormalities. So the progress with ATG and cyclosporin over the period has been restricted to around the 60 to 70% response rate. And that is why using a L-Trombopac in the upfront setting might have increased the response rate. But it's also important that look at long-term follow-up of these patients. This is a trial which was published nearly 10 years back using ATG and cyclosporin without GCSF. And this is an update after many, many years showing that the overall survival for patients is at 15 years is pretty good in this age category because these patients are monitored over a long period of time. So again, if you look at the algorithm, we've gone through this, less than 60, sibling donor, yes for transplant, no. And if they are more than 40, you would use HOS ATG with cyclosporin with or without L-Trombopac, depending upon the availability. But there are a number of issues which we need to address as well, because there are a number of patients with aplastic anemia who are refractory to treatment. They are ineligible or unfit for transplantation, predominantly the older group of patients more than 60, and no clear treatment algorithms available for them. So that is where the role of drugs like L-Trombopac, which is a small molecule oral compound, which is the thrombopoietin receptor agonist, has been used, despite finding that the TPO levels or thrombopoietin levels in patients with aplastic anemia being high. But that is not the only thrombopoietin receptor agonist, because in Japan and South Korea, there has been a significant interest in using romiplastin, which is given under the skin every week as a subcutaneous injection and showing good response at a higher dose. And there are other thrombopoietin receptor agonist agents which has come into vogue in the setting of ITP, which is another disease with low platelets with significantly less side effects and interactions. So obviously watch the space for these agents coming up in other countries as well. So the question is, if you are improving the outcome of patients with aplastic anemia with a triple drug regimen at the outset, will it replace the transplantation? Will this be the new standard of care? And what is it in older patients? So it is also important to note that there is a risk of relapse when L-thrombopag is withdrawn or cyclosporin is stopped as well. So that needs to be carefully managed with reintroduction of cyclosporin or reintroduction of L-thrombopag and cyclosporin. And this was again shown in the recent NIH updated publication, showing that despite a fantastic response rate to L-thrombopag, ATG, and cyclosporin, still 40% of patients relapse, but this relapse predominantly can be rescued with other treatments like introduction of L-thrombopag, introduction of cyclosporin. But thankfully, the high risk clonal evolution is only seen in a very small proportion of patients, but if it's important that this is monitored over a period of time as well. So one of the main things which the community in aplastic anemia is waiting is a randomized controlled trial of using ATG cyclosporin, compared them with ATG cyclosporin and L-thrombopag, and to look at the primary response rate. And this data was also presented in the EBMT meeting in March of 2021. And we are hoping to have the final outcome and data published in the literature. So essentially, these are patients randomized to these two arms, arm A, ATG cyclosporin, arm B, ATG cyclosporin with L-thrombopag, 100 odd patients in each of the arms. And these are the characteristics of the patients. A few differences is the median age of this patient cohort is 53 compared to the NIH data, which was 32. Quite a proportion of patients who are more than 40, nearly coming up to 65% of patients more than the age of 40, and similar number of patients. But importantly, also looking at their cytogenetics and genomic makeup as well. And this is some of the primary endpoint data which was presented by my colleagues over a period of time, showing that, yes, the phase 3 data also shows that there is an increase in the CR or complete response rates compared from arm A to arm B, with CR indicated in the blue, 22% CR and 37% PR. And at 6 months, a significant proportion, nearly 67-68% of patients achieving a CR or a PR. And importantly, these patients are transfusion independent. And we also looked at a number of genetic components in this. I won't bore you with this, but essentially to say that you do see significant clonal hematopoiesis and oligoclonal hematopoiesis in patients with aplastic anemia, but that does not mean that these patients have got MDS, and the proportion of mutations increase over a period of time as well. So the treatment algorithm for aplastic anemia has evolved over the last 30, 40 years, predominantly from an androgen-based regimen, then with an ATG and a cyclosporin backbone for the last 40 years, with addition of L-thrombopag and upfront use of L-thrombopag as well. So again, indicating that these patients have the treatment algorithm has evolved over a period of time. And this is how it looks like. So even you can reduce the age, or you can even consider transplantation, upfront transplant up to the age of 50, if the patients are fit and well with a good performance status and a good donor. Would you consider upfront sibling allograft up to the age of 50? If not, then you'd go into the standard algorithm. Even in children, there has been so much data about upfront unrelated transplantation rather than going to ATG cyclosporin and addition of L-thrombopag. We talked about, if no L-thrombopag in the upfront setting, if they do not have a donor, you would use L-thrombopag. If they have a donor, you would go in for an unrelated donor transplantation. So one of the main trials which the community in aplastic anemia was looking forward to was this trial, which is called SOAR trial, which is using L-Trombopac and cyclosporin as an upfront treatment for patients with severe aplastic anemia as a first-line treatment. Is a phase 2 interventional study, single arm, it's not randomized, and it's predominantly conducted in places where you do not have access to horse ATG and to cost pressures as well. There is only access to rabbit ATG, which we know has got toxicity. And reassuringly, we find that in patients with aplastic anemia, when you use a non-intravenous regimen, just oral regimen with cyclosporin and L-Trombopac, nearly 46% of patients do have a response, either as a CR or PR, predominantly as partial response, but some CRs, slightly less in patients over the age of 65. But importantly, nearly quite a lot of patients, nearly 70% of patients achieved the transfusion independence by 6 months, few adverse events as expected, but no directly deaths related to the study treatment. So this is a very promising trial, and hopefully we are waiting for it to be published in the full form. So this was presented in EHA as an oral as well. So I would say to conclude for aplastic anemia, and then I'll take up the PNH section, it is survival has significantly improved from the 60s down to now, and obviously important to rule out genetic causes. L-Trombopac both in the refractory and the upfront setting. Obviously, in older individuals, toxicity and tolerance is a big thing, so we need to look forward to see what treatment regimens. And it's important to continue to monitor for late effects, clonal evolution, and other complications. So if I switch gears and go to aplastic anemia, I'm trying to use the same cartoon we use. So what happens in PNH? So you still have the component of underlying either apparent or an occult bone marrow failure. But what happens in PNH is not only is the stem cells killed, but we think we all do carry these PNH stem cells in the bone marrow microenvironment, but they are very rare type of cells. But in aplastic anemia, because of the persistent immune pressure, your normal stem cells continue to be attacked by this immune dysfunction, but the PNH cells start expanding, which is one of the reasons we always say there is a continual relationship between AA, when it's totally empty with no PNH cells with pancytopenia, or PNH when it is a cellular bone marrow with loads of hemolysis and a PNH clone size, but a significant proportion of patients having a combination of both aplastic anemia and PNH. And we need to be extremely careful to understand what is the reason and what is the clinical symptom of these patients so that we can treat these patients depending upon what symptomatology, what PNH clone size they've got, what is the degree of hemolysis and the degree of cytopenia. So this is again a data from King's, which we published last year, or this year, I should say, where we looked at PNH clone in a large series of 3,085 patients with bone marrow failure, be it MDS or aplastic anemia. Again, to cut a long story short, even in MDS patients, predominantly the low-risk MDS, about 1 in 5 patients with MDS could have a PNH clone, while in aplastic anemia, nearly 50 to 60% of patients with aplastic anemia will have a PNH clone. So it's extremely common to find PNH clone predominantly in aplastic anemia, but not so in MDS, but doesn't mean that it's the PNH is the main culprit there. So you have to understand and delineate as what is causing the major symptomatology and treat appropriately. So we all know in the context of PNH, at least patients who do know about PNH, that it's an extremely rare disease. It is associated with hemolysis, i.e. destruction of the red cells inside the blood vasculature due to complement activation, giving rise to dark urine. They get blood clots in different parts of the body in atypical sites, and they have an underlying bone marrow failure. So what happens in PNH? So we know normal red cells are protected by complement regulatory proteins. In PNH, what happens is you have these red cells, which I call it to patients as naked red cells, or red cells which does not have shields around them, like the normal red cells. And whenever your complement is active, which is always active in somebody's system at a low level, this leads to hemolysis or destruction of the PNH red cells, leading on to anemia, free hemoglobin, and number of other complications due to nitric oxide depletion. We all know that for the last 20 years since the first clinical trial, or nearly coming up to 20 years since 2002, we know that blocking the complement can control the complement activation. And this is done by a C5 blocker called eculizumab, which binds with affinity to C5 and causes terminal complement cascade blockade. And patients derive significant benefit with blocking of it, with abolition of thrombosis, reduction of transfusions, and a good improvement in the quality of life. But we know that there have been a number of newer drugs which has come into the clinical trials or been marketed. So this was the drug which is called ravulizumab, which is given every 8-weekly intravenous for patients after a loading doses, which is modified from eculizumab, has the same mechanism of action, but has been engineered so that it lasts in a patient's system for a long period of time, so that it needs to be only given intravenously every 8 weeks. And this has shown to have significant impact on the patient preference and the quality of life, so that the patients have got 6 infusions in a year rather than 26 infusions in the year. And this has been approved in US and a number of other countries, and also in UK and Europe as well. And all these patients who are on eculizumab or switching over to ravulizumab or Ultomiris, and they're also getting very less frequently as well, and a stabilization of the treatment. So that is what ravulizumab is done for the patient population. And in US, at least, the patients have been switched to ravulizumab for the last 2 years at least. So this is how the structure looks like. But in EHA, the data for subcutaneous ravulizumab, i.e. given under the skin every week, was compared with intravenous ravulizumab given every 8-weekly. This is the phase 3 study. This is showing the data of the C5 concentration compared between ravulizumab given intravenously to subcutaneous ravulizumab given under the skin. And at least from this data, it looks like that it is not inferior between these two compounds. So the patients, or potentially once the final data of the trial is done and the outcomes are similar, there is a possibility some patients can go to every weekly subcutaneous ravulizumab, and this data was presented in the EHA as well. And this is just to give you a flavor of how many drugs are there either in clinical trials or either being taken out of the market or ongoing trials. Not only is there eculizumab and ravulizumab, but there's also a number of other compounds called trevolumab, which is a C5 inhibitor again, postelimab, which is a compound which is given subcutaneously, an antibody which is not being taken up for development, a daily subcutaneous injections, and also different modalities like an siRNA-based approach, indicating that there are a number of ways to target C5 with different compounds. But is that only the target which is available, or can there be other targets? And not to forget about the biosimilar. There are a number of biosimilars which has been done in clinical trials. This is specific to Russia, but there are trials of Samsung biosimilar and Amgen biosimilar, which are ongoing in a number of other countries as well. So, but people have been targeting upfront of the C5, i.e. broad C3 inhibitors with the APL2 or pegcetacoplan. So what is the data for this? So this was published this year in New England Journal of Medicine, showing that this drug, which is a C3 inhibitor, compared to eculizumab in patients who are still needing blood transfusions, and or anemic with the hemoglobin of 10.5. So these were the number of patients randomized, 41 to pegcetacoplan and 31 to eculizumab. This is a drug which is given twice weekly as an subcutaneous infusion every 3 days. And this showed a 3.9 gram per deciliter improvement in the hemoglobin compared to eculizumab, which again shows the superiority in this group of patients. And this is shown pictorially in patients who continued on the eculizumab. You can see the decline in the hemoglobin. This was the period when patients got both the compounds, and withdrawal of the pegcetacoplan, the hemoglobin went, while patients on pegcetacoplan had a very good stable hemoglobin. And the 48-week data was presented by my colleague Regis Pfeffel-Dilleter, showing the continuation of the responses and ongoing sustained improvement in the hemoglobin in both the treatment groups in a significant proportion of patients, but few side effects. Obviously, there were a proportion of patients who had to discontinue the treatment as well due to side effect profile, and there were patients who had to have significant breakthrough hemolysis. But it's an important addition to the treatment armamentarium of patients with PNH, showing that these drugs can work, C3 blockers can work, and a important thing to have for patients in the treatment cohort. So we covered about the broader C3 blockers, what is in clinical trials. But if we go now to other drugs which are factor D, factor B inhibitors like iptacopan, danicopan, and the Biocris compound BCX9930, what is the data and what was presented in EHA? So this is a data where we did a study of a factor D inhibitor, which is called danicopan, called ACH4471, in addition to eculizumab in PNH patients. And this is published in Blood now. But essentially to show that these patients were needing a number of transfusions over a period of time despite eculizumab, but on addition of factor D inhibitor danicopan to the backbone of eculizumab, these patients became transfusion independent, except one patient who had to have one episode of red blood cell transfusion. What do we know about the factor B inhibitor, iptacopan? This was again an update was presented in EHA, but was just published before EHA in Lancet Hematology by Professor Antonio Risitano and Regis Pfeffel-Dilleter, showing that in patients who were similar to the previous trial, having active hemolysis despite eculizumab, an addition of iptacopan, they were found that the patients could effectively stop eculizumab, and that the last update, I'm aware that all patients stopped eculizumab, but just continued on this oral factor B inhibitor, 200 milligram twice daily, and showing that this was the number of blood transfusions received prior to the entry into the trial, and this is during the trial as well. So,
danicopan is a new oral selective and potent.
Sorry, apologies for that. So again, data was shown in the upfront data in the context of patients who are treatment naive, and this drug has shown an efficacy in a small number of patients in phase 2 trial. So we'll look for the phase 3 trial as well. So we talked about factor B, factor D inhibitors, and there are other complement inhibitors as well, which have a role not just in PNH, but other diseases as well, and not to forget about the biosimilars. So just a word or two about COVID and aplastic anemia and PNH. Personally, I would say that all patients, if they do not have other absolute contraindications, should be advised to have a vaccination against SARS-CoV-2. Obviously, individuals need to weigh up the risk-benefit ratio. We have seen cases of worsening aplastic anemia and new onset aplastic anemia post the infection with SARS-CoV-2 or COVID, but not have seen any vaccine-induced or worsening aplastic anemia to my knowledge. In PNH, we have seen patients of hemolysis worsening after an infection, which is expected because it's a viral trigger. and also a couple of reports of vaccination triggering hemolysis and one case of thrombosis. So timing of vaccination could be potentially important because we believe that it should be given very close to the anti-complement therapy. And as a consensus, we've recommended not to have vaccination immediately after ATG and cyclosporin, but it should be done within a period of 6 months after you completed the ATG and cyclosporin. Obviously, happy to take up questions when we discuss this aspect over. And lastly is to talk about this global PNH patient registry. As some patients would know that quite a lot of the patients are on the Alexion-sponsored International PNH Registry. There is a big drive from IPIG, which is the PNH Interest Group International, which is also trying to do more patient-oriented but physician-focused patient registry. But I think in collaboration with AAMDS, International Foundation, and the NORD, this is a fantastic initiative which is trying to look at the global PNH patient registry. This is predominantly look at the quality of life, patient-reported outcome, and you can go into the AAMDS International Foundation website to register yourself. Obviously, this will be an anonymized data, and this is unique patient-related registry for PNH patients. And obviously, this could help to understand this disease, which is rare. And obviously, we are learning a lot from this. And this is the whole idea is that it's a data collection study for patients around the world. At the moment, the questionnaires are mainly in English, so it will be predominantly for patients who can understand it, but there is a significant drive to improve it so that it can be done in a number of languages. This is a registry for the patients so that it is not significantly interfered with physicians like me who have a habit in interfering with these things, but this is for you, by you, with support from the AAMDS and also scientific experts and physicians as well. And the whole idea is, can we increase the understanding and knowledge? So it's a natural history registry. Caregivers or guardians can do it as well. It's an anonymized and patients will have access to it. And there could be de-anonymized, de-identified data, which could be used to drive research, clinical trials as well. So I think with that, I will happy to stop there. Just lots of acknowledgements to a couple of my mentors, Professor Makti and Professor Marsh, number of people in the laboratory, clinical side, funding agencies, patients, other people, and also EBMT and fantastic colleagues who worked with the National PNH Service as well. But more importantly, patients, their carers, number of people who have always been a driving force and helped to spend more time with patients and understand the disease, and also to make a big change as well. So with that, I'm happy to take questions. I will stop my slide sharing and happy to take any questions which will come up as well. Thank you so much.
Thank you so much for the wonderful presentation. We do have some questions. Our first question is, how common is the transition from PNH to MDS?
Thank you, Lee, and thank you for that question. So it is something which we always look out for. So historically, 10 to 15% of patients with aplastic anemia over a period of 5, 10, 15 years have a risk of transformation to myelodysplastic syndrome or to acute myeloid leukemia, predominantly associated with chromosome 7 abnormalities and other complications. But in the era of L-Thrombopag used upfront, we are seeing this risk slightly at an earlier time point, like I showed in the data, but also able to identify which group of patients have a higher propensity to go to myelodysplastic syndrome, or can we identify these patients prior to the onset of MDS and leukemia so that therapeutic interventions can be done at an earlier stage before patients develop into a malignant disease or a clonal disease like myelodysplastic syndrome. So this is something which needs to be monitored over a long term, I would say even a lifetime of patients, so that we do not miss this unfortunate and dreaded complication, which could impair the, which could restrict the prognosis of the patients.
Thank you. Do we know if there is a benefit for PNH patients who are having breakthrough hemolysis on a C5 inhibitor to consider switching to the new 3C inhibitor?
Yeah, that is a very important question as well. So thank you again for the question. So this has been tested in clinical trials, which is the Pegasus trial, which is the APL2 pegcetacoplan, which is published in New England Journal, and updated 48-week data was presented. And that only chose patients who were anemic, who were needing either transfusions or were symptomatic of their anemia with a hemoglobin of less than 10.5. And it was shown that patients were able to be successfully switched, and the patients derived benefit with transfusion independence and improvement in the quality of life. But as with any treatment, obviously we need to wait for the long-term data for safety, because there is always a risk that these patients are at a propensity for significant breakthrough hemolysis when you're on C3 inhibitors. So the only slight unusual thing about your question was, I would suggest that patients who are symptomatic of their anemia and have significant clinically relevant extravascular hemolysis on a C5 inhibitor to potentially switch to C3, either if it's available or on a clinical trial. But for patients who get breakthrough hemolysis on eculizumab, then I would definitely transition them to ravulizumab or Ultomiris, which is given 8 weekly, which does not have the significant breakthrough hemolysis due to low level of drug in the system.
Thank you very much. This question is in regards to a female patient who is 36, has had aplastic anemia for 15 years. Sibling was not a match for a transplant, and over the years has had many transfusions. In 2008 and 2010, had ATG treatment and has continued to be on cyclosporine. She's had very high blood pressure and is now at the top of the blood pressure medication level. They are considering either switching to a different medication or a transplant. The question is a transplant made even more difficult with having many transfusions in the ATG?
Yeah, so again, obviously, apologies, I won't be able to, I'll take the question a bit more generically, but it's a very important aspect which you're bringing it up. So anybody who's not responded to ATG and cyclosporine, like what you have said, unfortunately, and also getting side effects and toxicity due to the cyclosporine, we would definitely think of changing treatment regimen. And in a patient of that age, 35, if there is no other significant comorbidities and the organ functions are good, we would usually recommend going towards an allogeneic transplantation as well. Patients who do have heavy blood transfusion dependency before the transplant will have problems with iron overload because you've accumulated so much ferritin on board, and potentially also multiple antibodies because of loads of blood transfusion. So those things need to be carefully evaluated by a transplant team and a transplant center, and also look at the suitability of the donor and suitability of the recipient before making that decision to change treatment algorithms. The outcomes with transplantation has been significantly getting better and better. So I would suggest that transplantation seems to be the right treatment option in this scenario, provided donor is available, there is no antibodies, and there is no comorbidities, and the organ functions are appropriate in the recipient.
Thank you so much. This question is in regards to patient registries. What are the benefits of patients signing up to be on a registry?
Yeah, I think it's a number of different things, because both the diseases we talked about today, aplastic anemia and PNH, is extremely rare. The incidence of these diseases are 1 to 2 per million. So there is no available expertise in a number of countries where you might see one PNH patient in your lifetime as physicians, or one aplastic anemia patient over a period of 10 to 15 years. So I think that is important, number one. Number two is also empowering patients as well, because these are patients who know about their disease extremely good. Yeah, sometimes they know more than their physicians who are treating them as well, at least in non-specialist centers. So it's important that the patient voice is heard and the patient is able to give their own perspective of their patient-reported outcomes and the quality of life, what is impacting, what is improved, what is not improved. And that will help us to understand and go forward this disease, which is still, although we do know a lot about these diseases, there are so many things we don't know. And that is how we'd be able to get more into the research domain. And it's also important that this research is answering patient-directed questions rather than physician-directed questions. So that is why I think registries are paramount interest and importance, so that we as physicians listen to patients and also able to focus on the questions you as patients want to know and ask as well, and refine. And it's also important that patients are part of that team so that the questions are asked appropriately.
Thank you so much. This is going to be a general question. Are there general recommendations for patients who are older than 65 that have aplastic anemia regarding the third COVID vaccine, or as some people refer to as the booster shot? Are there general recommendations?
Yeah, I think unfortunately there is no data yet on how much response a patient who's got aplastic anemia at age 60 gets to 2 doses of COVID vaccination versus somebody who's 60 who does not have aplastic anemia. My guess is you will have around 60 to 70% response. But the second thing we don't know is how long does the response last? So does the immunity go down? Both your antibody response, i.e. B cell response, and also the T cell response. Yeah. So I would suggest that if an offered a booster vaccine or a third primary dose by the respective governments in the country, I would suggest that you would want to receive the booster vaccine to augment the antibody and the T cell response, so that your ability to transmit COVID and your potential of getting serious infections is dampened. So yes, for a third dose, unless there is absolute contraindications for that patient.
Thank you. In regards to receiving the COVID vaccine for PNH patients, is there a best timing to receive the vaccine? Should that be spread out as not to interfere with treatment time? And does the treatment time in the vaccine then potentially contribute to the concern for PNH patients with the risk of severe hemolysis?
Yeah, so that's an important question, Lee, as well. And thank you again for the question, because I did touch upon it briefly in my discussion and presentation. Again, it's a data-free zone. Yeah. But what we would recommend ideally as a PNH center in UK and in King's in London is that we would recommend that vaccination is given as close as possible to the recent eculizumab or ravulizumab or pegcetacoplan infusion, because thereby at least you got enough complement inhibitory potential or the drug on board that you potentially alleviate or abrogate the complications associated with vaccine-induced complement activation and a potential pharmacodynamic breakthrough.
And our next next question is, how are patients with mild or moderate aplastic anemia treated? How is that treated differently than, say, severe or very severe aplastic anemia?
Yeah, again, that is a very important question and a pertinent question as well. So patients with very severe and severe aplastic anemia obviously do not have much time. They have to be treated immediately as per the appropriate algorithm. Patients with non-severe aplastic anemia fall into two categories. There would be mild cytopenia, and the patient's quality of life would be normal. They would not have bleeding, infection, or symptoms of anemia. Those patients could be very carefully monitored based upon the symptoms and the blood counts, and sometimes nearly 40 to 50% of the patients, nothing changes. Yeah. In the rest of the patients with non-severe aplastic anemia, there could be a progression to severe aplastic anemia immediately or over a period of time. But also important, if you see a 20-year-old or a 25-year-old who's got the full life ahead of them, but they have non-severe aplastic anemia, they're transfusion independent, but they're very symptomatic of their cytopenia, then we would still advise those patients to go into immunosuppressive therapy, be it ATG cyclosporin or with ATG cyclosporin and L-trombopag in countries where it's available, to treat so that at least their symptom burden is getting better and their quality of life is getting better. And definitely they will have a higher chance of response to immunosuppression, because younger age and non-severity of the disease are still some of the factors which can predict someone responding to therapy with immunosuppressive therapy. So symptomatic non-severe aplastic anemia, even if they're transfusion independent, should be treated. Transfusion-dependent non-severe aplastic anemia or moderate AA patients could also be considered for treatment similar to the SAA algorithm or severe aplastic anemia algorithm.
Thank you. Our next question is, what is the significance of platelet antibodies? If a patient has them, would it be recommended for transplant over immunosuppressive therapy?
Yeah, so there are a couple of things which this question might lead on to. Yeah, one is that because patients with aplastic anemia are very low in their platelet counts, they would need platelet transfusions regularly to increase the platelet count and stop them from getting a risk of bleeding. But by doing so, there is also a potential risk that you're potentiating the development of antibodies against platelets. Or very rarely, although not uncommonly, we see patients even presenting at the outset of their diagnosis of aplastic anemia with multiple HLA and HPA antibodies, which is human leukocyte antigen and human platelet associated antigen antibodies. So those patients could have developed this sensitization because it's predominantly seen in young women who had multiple pregnancies before as well. So it could be that the pregnancy itself had induced, sensitized and made them develop antibodies. So for those, you need to be extremely careful about giving them appropriately matched platelets in discussion with your transfusion laboratory and colleagues as well. And also watch for increment of the platelet count, because you don't want the platelet count to be very low to stop them from risk of bleeding. So per se, presence of an HLA antibody or a platelet antibody does not mean that this patient should be taken to a transplant rather than to immunosuppressive therapy. But if you feel that you will have significant problems maintaining and giving the platelets, and there is a compatible donor available, there is a possibility you should consider them from an urgent, related, unrelated transplantation, or very rarely haploidentical transplant in the absence of antibodies for that donor for transplant procedures rather than ATG and cyclosporin.
Our last question is, this patient has had severe aplastic anemia for 20 years, and their treatment was ATG and cyclosporine. Is it too late to try Promacta that you spoke about? And would you use both drugs together or just one of them for low counts?
Yeah. So thank you again, Lee, for the question. And it's an important one because I'm assuming you're considering treatment because you're still needing blood transfusions or platelet transfusions for the aplastic anemia, which is why you want to have treatment. So yes is the answer. Direct question. Obviously, I can't be very specific about each individual scenario. It depends upon what the bone marrow shows, what is your clinical status, what are you eligible for treatment, and why did not ATG work? Did it work and did you lose a response, which is relapse rather than refractoriness? So those factors needs to be considered into the equation. But if those are considered and your local physician or the hematologist think you should go into Promacta or L-Trombopag, I would suggest that there has been some benefit in addition of cyclosporin to L-Trombopag in augmenting or inducing a better response. But again, you have to, each case needs to be taken individually into consideration and discuss with your local team.
Thank you so much for the wonderful presentation and taking the time to share all of your expertise with us today. It's very much appreciated. And if you'd like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If you have any additional questions, you can send it to us at any time in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, extension 2, or submit a question to our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 38 years. This concludes our program, and thank you again so much for the presentation.
Thank you. Pleasure. Thank you.